Good morning, everybody, and thank you for joining us for the Iowa ACC Echo Lecture Series. I'm guessing you can all hear me okay. I'll take that as a yes.
Yeah,
Uh,
we can hear you.
Thank you. So this is day 5, the third weekend of our lectures. We have this weekend and we have another weekend. Um, as a reminder, please keep your microphones and your videos off at all time. Refrain from using any annotations. But please feel free to ask any questions on the chat window. Shubhadeep Roy, our FIT co-chair, and Jay Parekh, along with me, join in welcoming you to the session today, and they will be moderating the Q&A at the end. So if you have any questions, please feel free to post them in the chat window. And if you have any further suggestions or any other thoughts about how we can do better on these lectures, please feel free to share this information with us too. And also a last minute change, instead of 4 lectures today, we will only have 3 lectures. The speakers had some conflict. So we'll be wrapping up early today, but we will be adding that lecture to the next weekend session. So without further delay, I'll go ahead and introduce our first speaker, Dr. Isabella Grumbach. Dr. Grumbach is a professor in the Department of Internal Medicine and Radiation Oncology at the University of Iowa, and she's also the vice chair for research in the Department of Internal Medicine. She graduated from Ruhr University Bochum before training in cardiology at Georg August Universität Göttingen in Germany. Isabella, I apologize if I crucified any names over there, but she came to the US to pursue a career as a physician scientist and completed clinical training at Cook County Hospital and Emory University, and further postdoctoral training at the University of Illinois and Emory University. Dr. Grumbach's clinical interest is in cardio-oncology and in general cardiology. She regularly attends in the Echo Lab and has an active VA, NIH, and AHA-funded research program that focuses on vascular dysfunction after radiation and other cancer therapies. She is a member of the AHA Cardio-Oncology Committee. So Isabella and I together, we started the Cardio-Oncology Clinic at the University of Iowa, which is doing very well. And she is going to be talking to us today about Cardio-Oncology Echo. Over to you, Isabella.
Thank you very much for this very kind introduction. Let me just put this in presentation mode. Okay, all right, so good morning, and I'm so glad to be here with you. Welcome to the new and blossoming world of cardio-oncology. You may have noticed by looking at your echo preparation material that cardio-oncology at this point is not a separate topic area for the board exam. However, you may have also seen that the American Society of Echocardiography just started a cardio-oncology interest group. So my prediction is that in the next few years, you will see a steady increase in the number of questions regarding oncology. This is to some extent also driven by the fact that, especially in 2020, there's been a number of interesting, very well-performed studies on imaging and cardio-oncology published, which in the near future will probably become fair game for questions. As you probably know from some exposure to cardio-oncology, echocardiography can serve a number of purposes for the clinical practice of cardio-oncology, mostly risk stratification before therapy, surveillance during therapy, and follow-up after the end of therapy. So these are the 3 big conceptual areas in which echocardiography is used. Which adverse events can be detected by echocardiography? Well, the most obvious one is LV dysfunction or cardiomyopathy, which can be induced by a number of cancer therapies, including anthracyclines and HER2 antagonists, such as trastuzumab and its derivative. And if anything, questions will probably focus on anthracycline and HER2-induced cardiomyopathy. But I would also like to point out that tyrosine kinase inhibitors, radiation therapy, proteasome inhibitors, and a number of the great new cancer therapies which are coming online and are getting used more and more frequently induce LV dysfunction. Echocardiography has been used to diagnose and guide therapy for immunotherapy-induced myocarditis, although the evidence for this is just starting to come online. It also helps to detect the side effects regarding valvular heart disease and pericardial disease. And I will just start by saying that there are no particular recommendations how to use echocardiography for the follow-up of cancer therapy-induced valvular disease and pericardial disease. So for those, the general guidelines would apply. So just before I come to the first question, just a reminder that the incidence of cardiomyopathy or LV dysfunction is quite significant for a number of different cancer therapies. Of course, anthracyclines, trastuzumab up to 28%, but also to the same also applies, however, to alkylating agents such as cyclophosphamide, and significant incidence also for TKIs and proteasome inhibitors. Okay, so let's start with the first topic area, which is risk stratification before therapy. Oops, I'm sorry, I'm going backwards. My slides. Here we go. So here's case number 1. This is a 55-year-old female who somebody curbsides you on. She has breast cancer stage 1B. She already had a mastectomy and lymph node biopsy with dissection. And the oncologist wants to treat her with a regimen called DDAC, which is dense dose adriamycin and cyclophosphamide, as well as radiation therapy. And of course, adriamycin is an anthracycline. Other medical history includes diabetes, depression, and migraine. The patient has vital signs as shown below, and her cardiac exam is completely normal. So is a TTE indicated for this patient, and how should the imaging be performed? Should all patients undergoing chemotherapy with anthracycline have a baseline TTE? Should the study include an assessment of diastolic dysfunction? Because baseline diastolic dysfunction, especially grade 2 and higher, increases the risk of MACE during chemotherapy with anthracyclines. Should the study include an assessment with GLS, because its addition to 2D LVEF significantly and incrementally improves the prediction of MACE? Or should the study include an assessment of circumferential strain, because an abnormal circumferential strain value has a high predictive value for MACE? Okay, think about this for a second. So here's question number 2. There is obviously a strain imaging on the right. And the question is, the strain curves in this picture are least likely to be which of the following? Radial strain, longitudinal strain, circumferential strain, or is it least likely to be longitudinal strain and circumferential strain? And I probably don't have to point this out to you, but below here is the EKG, QRS complex, T-wave, and so forth. Okay, take a look at this for a second before we move on to the third question, which actually has been on the boards. Which of the following is considered a normal global longitudinal strain GLS value? Is it -14, -23? Or is the normal GLS value as indicated by the vendor? Or is it B and C -23% and as indicated by the vendor? Okay, so which patients require echo imaging prior to cancer therapy, mostly chemotherapy? So the best evidence, actually I probably shouldn't say evidence, but the most commonly used guidelines are the ASCO guidelines, which were published in 2017 and really are the standard for practice at this point. Again, the evidence for many of the points in these guidelines are not very strong. the guidelines recommend that patients at an elevated risk of developing cardiotoxicity should have a baseline TTE study before initiation of therapy, and the elevated risk includes anthracyclines at a dose of more than 250 milligrams per meter square for doxorubicin, radiation therapy with more than 30 gray, a combination of anthracycline-containing chemotherapy plus radiation at lower doses, the use of HER2 inhibitors, and increased cardiovascular risk factors. What is the evidence for doing a baseline TTE study? So this is a often cited study from 2015, which followed up patients for up to 5,000 days after imaging who underwent chemotherapy studies. And the distinction here is patients whose LVEF is more than 5 points higher than the lower limit of normal for the echo lab, patients with an in-between LVEF between the lower limits of normal and 5 percentile points above this, and patients whose LVEF is lower than the limit of normal for the echo lab, showing that there is a strong separation between patients who have a high normal LVEF and those with a decreased LVEF. Now, the addition of global longitudinal strain to predict MACE has been studied in a number of different clinical studies, including, again, this one from the same group, who followed up patients and distinguished between a GLF greater of minus 17.5 and a GLS reduced to less than minus 17.5, and also here detected a strong separation in these groups in terms of MACE in the following 3,000 days after the study, leading to the conclusion that adding GLS to LVEF is significantly better in terms of predicting MACE after cancer therapy than clinical variables by themselves. Probably a fair game for the boards, and again, I think this has been asked before, is what is the cutoff for GLS? There are a number of studies in the last few years which have used slightly diverging cutoffs. However, the current recommendation of the current consensus is that minus 18% is a reasonable cutoff for the lower limit of normal, but also there are some vendor-dependent differences which also should be taken into account. As for the relative change in GLS during treatment, the current consensus is that minus 15% relative change is considered as the cutoff. So if we go back to our first three questions, should all patients undergoing chemotherapy with anthracycline have a baseline TTE? So according to the ASCO guidelines, the answer is probably no. This TTE at baseline should be done for patients receiving more than 250 milligrams per meter square of anthracyclines or undergo a combination therapy with radiation. However, patients who will receive trastuzumab should have a baseline TTE evaluation. Diastolic dysfunction, especially a baseline diastolic dysfunction, has not consistently been shown to be a good indicator of MACE. So for B, there really is no evidence at this point, or at least no conclusive evidence. As for C, this is true, and the study should include an assessment of GLS because its addition to a 2D LVF significantly increases the prediction of MACE. And as for D, here the point is that there is not very good evidence that circumferential strain, in contrast to global longitudinal strain, is a strong indicator of impending MACE. And also, if anything, an abnormal strain value is, or a normal strain value really helps you just, I should say, no, normal, well, I'm confused now. And so a normal strain value really is probably a very good negative predictor for the subsequent development of MACE. So as for the strain patterns, you probably know that speckle tracking allows for a fast automated strain analysis. And you also probably remember that there is a depiction in colors, in shades of red, to depict shortening or thickening and systole, and in blue to depict thinning and lengthening. And the distinguishing factor between the radial strain and the circumferential and longitudinal strain is that the radial strain actually depicts the thickening and systole, and therefore this is the only strain modality where the strain gives a positive value, meaning that the curves that we saw before, which showed a negative deflection in systole, is very unlikely to be radial strain, which again should give a positive deformation during systole. And as you probably remember, which of the following is considered a normal GLS value? So here the best answer is probably B and C. A value which is more negative than -18 would be considered normal by most vendors. However, there are some vendor-specific variability. So B and C is the correct answer in this case. So now let's move on to surveillance during therapy. Here is our next case. This is a patient who is being referred for asymptomatic decline in LV function, which is really the bread and butter referral for cardio-oncology clinic. The patient has right-sided breast cancer. It's a T2, it's HER2 positive and ER and PR positive. The patient already underwent mastectomy and lymph node biopsy. She had a baseline TTE and now is undergoing neoadjuvant therapy with a regimen called APT, which includes Taxol and trastuzumab. This therapy includes paclitaxel plus trastuzumab weekly for 12 weeks, and then is followed up by another 9 months of trastuzumab treatment every 3 weeks. The second TTE was performed after the first 12 weeks were completed, and now the LVEF has decreased from 61% to 49%, and there's a GLS of -15.7. Unfortunately, no GLS was performed during the baseline study. The patient has a history of hypertension. She's 62 years old. When she comes to clinic, her blood pressure is elevated and she's also very nervous, but otherwise her cardiac exam is normal. So this is actually a real world TTE from this particular patient. This is just for apical 4-chamber view. The LVEF by 2D measurements was measured at 49%. You can also see that the images are not perfect when it comes to definition of the endocardial border. And this is the summary picture of the GLS measurements. Here again, the GLS was slightly abnormal at -15.7. So how often should repeat surveillance studies be performed in a patient during cardiotoxic chemotherapy? Should all patients on anthracycline-based chemotherapy be imaged every 3 months? However, there's no recommendation for trastuzumab-based therapies. Is cancer therapy-related cardiac dysfunction, CTR-CD, defined as a decline in LVEF by 15% to below the lower limit of normal, or a decline in GLS by 10%? Should asymptomatic patients with CTR-CD be started on cardioprotective therapy and re-imaged in 3 to 4 weeks if they have, again, no symptoms, but a decline in LVEF? Or D, in asymptomatic patients with CTR-CD, repeat studies should be performed every 12 weeks. Okay, question 5. Which imaging modalities should be performed in surveillance studies for CTR-CD? The repeat assessment of LV function should be done by 2D imaging with contrast because it is less variable than imaging with 2D alone. The repeat assessment of LV function can be done by 2D imaging with contrast or by 3D imaging because their temporal variability is comparable. A change in LVEF by 3D imaging or by cardiac MI is more likely to represent CTR-CD than a change in 2D LVEF, or is it D? Changes in GLS can predict subsequent decline in LVEF, but whether these measurements can be used for clinical decision-making regarding initiating cardioprotective therapy is currently unknown. Okay, so let's go back to the ASCO guidelines. So the ASCO guidelines state that repeat studies are recommended for symptomatic patients and that surveillance imaging may be offered during treatment in asymptomatic patients who are at increased risk. The frequency of surveillance studies should be determined based on clinical judgment and circumstances. And no recommendation can be made at this point regarding the continuation or discontinuation of therapy on individuals with evidence of cardiac dysfunction. When it comes to the use of HER2 receptor antagonists, the imaging should be performed every 3 months. Okay, so what is actually the definition of cancer therapy related LV dysfunction? The ASE has given the definition that a decline in LVEF of more than 10% to an LVEF of less than 53% is considered abnormal, and so is a decline in GLS of more than 15%. The ASCO recommendations for surveillance with subclinical LV dysfunction currently are as follows. They are to initiate guideline-based heart failure treatment, to do close follow-up and repeat TTE, usually before the next cycle of chemotherapy is to be initiated, and also to include a discussion to delay the next cycle if LV dysfunction is persistent. Before we talk a little bit more about trastuzumab and surveillance of LV dysfunction in trastuzumab treated patients, I just wanted to show you this slide of a frequently cited study which shows that the administration of doxorubicin, shown in orange, trastuzumab in green, and the combination therapy, even in asymptomatic patients, leads to a decline in LVEF, which is persistent at 3 years, but it really is very small. The use of doxorubicin led to a decline in LVF by about 4 percentage points, trastuzumab by about 2 percentage points. So a very small decline in LVF is not uncommon in asymptomatic patients. However, when it comes to the follow-up of patients with trastuzumab-induced LV dysfunction, the current recommendations are about as follows. If LV dysfunction is seen at reassessment and the drop is asymptomatic, the recommendation is to initiate heart failure therapy and perform reassessment at 3 weeks to about a month before resuming trastuzumab containing chemotherapy. And now what I would like to point out before we come to the next discussion point is that for a typical cancer treatment regimen, as shown here for a patient with early invasive HER2-positive breast cancer, where the therapy usually starts with an anthracycline-containing chemotherapy and then contains trastuzumab or pertuzumab therapy for a long time, usually a year or longer. This leads to a great number of echo studies over the course of treatment, which leads to the next problem that we currently see in surveillance studies and the interpretation of surveillance studies. And this is in order to be able to really detect cancer therapy related decline in LV function, the studies by echocardiography need to be performed with an imaging modality which has very low temporal variability. Like the decreases in LV function that we see in this patient population may not be very large, maybe 10%, maybe 12%. And in order to really reliably detect them, it is really critical to use imaging modalities which have low variability, such that a slight decrease in LV function can really be interpreted as a result of cancer therapy and not just of variability of a study. And so this problem really has been investigated in a number of trials. So this is the first one by a Canadian group which assessed the LV temporal variability in 56 patients with stable LV function by GLS, and the patients were imaged 5 times over 12 months. And what you see here is the temporal variability with a confidence interval for 2D imaging with contrast, a LVF here by biplane method versus a triplane method compared to 3D imaging. And the conclusion from the study is that the temporal variability of LVF performed by 3D measurement is a lot lower than if performed by 2D imaging with biplane method. And the addition of contrast imaging actually increases the variability instead of, as you probably would have expected, decreasing it. So the same group published another study on the same topic in 2020. And here, not only asymptomatic patients were included, but also patients that actually developed CTR-CD during the course of therapy. And so the imaging was performed by 2D, 3D echo imaging, as well as cardiac MI, and the echo studies, as well as the MRI, also included an assessment of global longitudinal strain. There were two groups of normals. There were healthy volunteers, as well as cancer patients that did not develop CTRCT versus those who did. And probably the best way to look at this study is to look for an imaging modality which gives the best separation between normal patients, volunteers, or patients without CTRCT versus those who did develop CTRCT, as shown in blue. So for which imaging modalities is the separation the largest, and the confidence intervals are the best, are best separated. And so the answer to this is maybe the best modalities according to this study are 3DEF, which really gives a better separation between normal LV function and CTRCT patients compared to 2DEF, and cardiac MRI fares about as well as 3DEF or echo imaging with global longitudinal strain. The use of GLS in a number of studies has been shown to be a good predictor of impending cardiac dysfunction, as shown in this study, where the association between early changes in a number of parameters, including longitudinal strain, was used to predict the subsequent change in 2DF. And so the conclusions from this study were that global longitudinal strain was actually well suited to predict a subsequent change in LVEF in patients with doxycycline or trastuzumab containing therapy. Now, the probably even more interesting study is this one, the SUCOR trial, which was published last year and actually has received a lot of attention. And so this study asked whether GLS-guided cardioprotective therapy prevents a reduction in LVEF and the development of CTRCT in high-risk patients compared to the usual care. 300 patients were included, and the initiation of cardioprotective therapy was guided either by a reduction in GLS or by a reduction in LVEF. The patients were followed for their LVEF and the development of CTRCT with a symptomatic reduction in LVEF over 1 year. Now, interestingly, the primary outcome, the change in LVEF, was not significantly different between the two groups. However, the secondary outcome was significantly different, with a greater use of cardioprotective therapies in patients who were started on therapy based on a decrease in GLS, and fewer patients in the GLS-guided than the VEF-guided arm met the criteria of CTRCT at the end of therapy. Now, while the interpretation of this trial is still somewhat up for debate, the authors of the study probably rightfully pointed out that the secondary outcome, which compared the existence of CTRCT criteria between the two groups, pointed towards a real benefit of basing the begin of cardioprotective therapy on GLS. And actually this is shown in this slide, in which on the top, the patients who received cardioprotective therapy were compared, and the decline in LVEF over the 1 year period was 3% in the patients who were started on therapy based on an abnormal GLS value versus those who were started after the LVEF had dropped. Just one slide on diastolic dysfunction as a predictor of subsequent CTRCD. So there's mixed evidence in far fewer studies. However, a relatively recent trial pointed towards a predictive value of a decrease or worsening in diastolic dysfunction during chemotherapy. And this was associated with a twofold risk of developing CTRCD and a reduction in LVEF over time. But again, there's mixed evidence and really one very convincingly positive trial. So maybe more needs to be done in this area before this will really become a broad question. So now let's come back to question 4, 5, and 6. How often should repeat surveillance studies be performed in a patient during cardiotoxic chemotherapy? So A is incorrect. There is a recommendation to perform trastuzumab-based, to perform studies for patients undergoing trastuzumab-based therapies every 3 months, but there is no clear recommendation how to follow up patients on anthracycline-based chemotherapy. B is incorrect because I switched the numbers. A decline in LVEF by 10% is considered TCR-CD, or a decrease in global longitudinal strain by 15% or more is regarded abnormal. So again, the numbers are switched. However, C is correct. Asymptomatic patients with CTRCT should be started on cardioprotective therapy and be re-imaged in 3 to 4 weeks, which usually is before the next cycle of chemotherapy is administered. Asymptomatic patients with CTRCT probably need to be imaged more frequently than simply every 12 weeks. So I think D is incorrect because an increased frequency of imaging is required in an asymptomatic patient with CTRCD as suggested in C. Okay, when it comes to the imaging modalities, the repeat assessment of LV function should, if ever possible, be done by 3D imaging. The addition of contrast to 2D imaging does not really change the variability in the measurements. It's also not correct that the repeat assessment of LV function by 2D with contrast has the same temporal variability as 3D imaging. Again, the best or the lowest temporal variability is seen with 3D imaging. And as for D, the changes in GLS do indeed predict a decline in LVEF, but there is now data suggesting that GLS can be used for decision-making regarding the initiation of cardioprotective therapy based on the recently published SOCOR trial. And C is correct because the LVEF imaging by 3D or by CMR is more likely to represent CTRCD than a change in 2D imaging, because the variability with the two modalities, 3D imaging or CMR, is the lowest, and therefore any change seen with these imaging modalities is most likely to, or more likely to represent CTRCD than a change seen by 2D imaging. So what about follow-up by follow-up echocardiography studies after the end of cancer therapies? So this is another real-world patient. This is a patient who unfortunately has recently been diagnosed with relapse of AML and he's referred for risk stratification prior to chemotherapy and then bone marrow transplantation. He has this history of acute AML, which was diagnosed and treated in 2009. And he actually underwent at that time chemotherapy with anthracyclines. To your dismay, no echo study has been performed since 2009. He has a past medical history which includes paroxysmal atrial fibrillation. The patient is 57 years old, comes to clinic. His heart rate is 105 per minute, but it's regular. Blood pressure is relatively low. He has a 2/6 systolic ejection murmur, but no edema. Yes, so this is obviously, this is the measurement in the past a long axis, and you see that the left ventricular and diastolic dimension in diastole is not normal. And so this is the apical to, this is the apical window. Here the imaging performed with the LVF was calculated by 2D imaging with contrast, which I know you know is not ideal. It would have been better to have a 3D imaging of this. And the global longitudinal strain in this patient actually was abnormal. It was -12. Okay, so this is a little bit a case of things not have gone very well for this patient, but the question is, how could this have done differently? And what do we actually know about the use of imaging after the end of chemotherapy? Should patients who have received anthracycline-containing chemotherapy have a TTE within the first 12 months after completion of therapy? Should patients who have completed HER2-containing chemotherapy have a TTE within the first 12 months after completion of therapy, and then repeatedly every 5 years? And when it comes to anthracycline-induced cardiac dysfunction, is the chance of recovering LV with LVEF with guideline-based treatment less than 30%? Okay, so for this particular complex of questions and problems, there is some trial evidence and there are some guideline statements. In fact, there are a number of different guideline statements for the frequency of follow-up. So this is actually from the European guidelines. There is really no new ACC guideline at this point. The recommendations for anthracycline containing chemotherapy are probably more straightforward at this point, and they're also far more accepted. Here, the recommendation is to perform a follow-up imaging TTE study within the first 12 months after the final cycle of chemotherapy, maybe in high-risk patients who have received a high dose of anthracyclines even within the first 6 months after the last cycle. But here there is no agreement, but I think all statements do agree that within the first 12 months after the end of chemotherapy, repeat TTE imaging is indicated. And after this, it should be performed about every 5 years. And in patients who have had some side effects or have received a high dose, it should probably be done annually for the first 2 or 3 years. On the right-hand side are the recommendations for HER2 targeted therapies. And here I think the take-home message is that it's really not clear how the follow-up for these patients should be done after the end of chemotherapy. So when does LV dysfunction occur after the end of chemotherapy with anthracyclines? There's good evidence suggesting that it really occurs in the first year, most commonly, and after the first year, a new diagnosis of LV decline is relatively uncommon. And when it comes to initiation of therapy, the same group published very nice evidence showing that the sooner after LV dysfunction has been detected, the sooner the guideline-based heart failure therapy is initiated, the greater the chance of recovering LVEF on baseline, on guideline-derived heart failure therapy. And in fact, there is a substantial separation between patients who do respond versus those who do not respond, meaning they do or do not recover LVEF after initiation of guideline therapy, as shown in this slide. The chance of cardiac event-free survival is far higher in those who responded to therapy after anthracycline-induced LV dysfunction was detected. So to come back to question 6, the first option is the right one. Every patient who has received anthracycline-containing chemotherapy should have a TTE within the first 12 months after completion of therapy, and afterwards repeat imaging is indicated for some patients probably every year for the first 3 years, and then every 5 years. In contrast, as this is option 2, there is really no good agreement on how patients with HER2-derived therapies should be followed up. And as for anthracycline-induced cardiac dysfunction, there is a good chance to recover LVEF on guideline-based therapy, especially when therapy is initiated early on. I will just for a minute talk about ICI-induced myocarditis. As I mentioned before, there are no particular guidelines or statement papers or even trial data on how to follow up pericardial disease and valve disease related to cancer therapy with echocardiography. I will try to make this very brief so that we have a minute or so for questions. This is another case of a patient who unfortunately developed immunotherapy-induced myocarditis, 65-year-old gentleman who had been started on nivolumab and ipilimumab 12 days before becoming sick with chest pain, fatigue, and dyspnea. And interestingly, the LVEF was preserved at 73% and no regional wall motion abnormalities were seen by echo. Nevertheless, the patient had a bad outcome. He was rightfully diagnosed with myositis and myocarditis, started on high-dose steroids, but developed refractory ventricular tachycardia about 24 hours after admission. So you may be aware that ICI-induced myocarditis has an interesting, somewhat different presentation from what we often see with myocarditis by other causes, and that is that it is often accompanied by symptoms, other symptoms such as myositis, and that the heart failure symptoms are relatively less common. 50% of all patients with ICI-induced myocarditis have an EF above 50%, which has led to the question whether imaging by echocardiography or cardiac MI can and how it should be used in the setting of ICI-induced myocarditis. So this is another fairly recent trial which looked at the use of global longitudinal strain in predicting and diagnosing ICI myocarditis and predicting MACE. here, so here this is a retrospective study in which 113 myocarditis cases from a registry were reviewed, and a number of patients were actually imaged with global longitudinal strain, and 30 additional patients had global longitudinal strain imaging before and during therapy. And what this trial actually showed is that in patients in which the LVEF was preserved, a reduction in global longitudinal strain was actually frequently seen, and lower global longitudinal strain was also more frequently seen in patients who had bad outcomes, which points to a use of global longitudinal strain in ICI myocarditis as a predictor of poor outcomes, especially in patients who have a preserved LVEF. So the limitations at this point when it comes to imaging in cancer therapies is that there are relatively limited data outside of anthracycline and trastuzumab-based chemotherapies, and the currently available studies have relatively small sizes. So I believe that maybe for another year or two, the number of questions related to cardio-oncology will be relatively limited. However, I also predict that starting maybe this year, but certainly next year, you will certainly see a flurry in questions related to this topic. And thank you, and I'd be happy to answer as many questions as possible, and good luck on the boards.
Thank you, Dr. Grumbach. That was an excellent talk. There are a couple of questions in the chat box.
Okay.
The first one is, can you hear me?
Yes.
Yeah, so the first question is, if a patient has, say, grade 2 or grade 3 vascular dysfunction at baseline, would that be a reason to avoid anthracyclines?
So the answer is, unfortunately, there is no data on this. There is no data to sway you one way or another. This is probably not really a kind of a broad question, but given the lack of data, I would assume that most practitioners in the cardio-oncology field would recommend more frequent follow-up studies. But based on diastolic dysfunction per se, at this point, there is no evidence and no clear recommendation.
The second question is, for surveillance, should you use the same type of imaging every time? Like, for example, if you use 3D the first time, should you keep doing 3D?
So the answer is yes, wherever possible. So I in my clinical practice, I've seen a lot of confusion when, study one had one modality and the next study then had another modality and then the third one and so forth. So the answer is yes, wherever possible. Maybe the most helpful recommendation is to try to use the same modality for all studies. And a 3D LVEF is most helpful, and GLS also really should be performed with every follow-up study.
And I think the last question I have is, if you can explain again, what are the next steps to reinitiate chemo if there is subclinical LV dysfunction?
Yes. So it depends a little bit on the degree of LV dysfunction and the chemotherapy, and sometimes it really also depends on the patient and what the patient's other options are. So the way how we usually handle these cases is by initiating guideline-based therapy and re-imaging at a time point before the next cycle. And this is in particular true for patients who are asymptomatic or minimally symptomatic. Also, if the LVEF hasn't dropped to what most cardio-oncologists would regard as the danger zone, and this is an LVF below 40. So again, if the LVF drops mildly, the patient is asymptomatic, initiate therapy, get another imaging study before the next cycle. If the LVF remains decreased, then this then leads to a discussion with the oncologist. If there are symptoms, some of the questions will resolve around have the symptoms resolved, and has the LVF improved, or at least not further worsened before initiating the next cycle. Most cardio-oncologists regard an LVF of less than 40% as a reason to recommend the discontinuation of anthracycline-based chemotherapy. When it comes to trastuzumab, there is data suggesting that continuing therapy can be handled more aggressively. So the indications to discontinuation there really are the development of symptoms and a significant decrease in LVF to 35 to maybe 35%, less than 40%, 35%. It often also depends on the patient. If this is the patient's only option to improve their overall survival, we do the best we can and we bite the bullet. We've done this a few times.
I think those are some excellent questions from the audience too. So I think I have no more questions. I will hand off to Dr. Ashwin.
Thank you very much, Isabella. That was an excellent review. Really appreciate your contribution to the lectures. Thank you very much for doing this. Going to move on and introduce our next speaker, Dr. Rajiv Ruben Fernando. Dr. Fernando completed his medical degree at St. John's National Institute of Health Sciences in Bangalore, India. He completed his internal medicine residency at University of Texas Health Science Center in Houston, Texas, and his cardiology fellowship at University Health Science Center in Houston, Texas. He completed an advanced cardiac imaging fellowship at Loyola University Medical Center in Maywood, Illinois. He was recruited to the University of Louisville and served as a director of cardiac MRI research and participated in clinical and research in cardiovascular MRI. And he subsequently joined Unity Point Clinic Cardiology in March of 2017. His academic interests include 3D echo, cardiovascular MRI, and cardiac CT. Rajiv has also been very active with the Iowa ACC Strategic Council and helped us with the Early Career Conference. We definitely appreciate his contribution to the lectures here and to his participation in the Early Career Council. So I will let Rajiv take over.
Good morning, everyone. It's always hard to follow an excellent speaker like Isabella Grumbach. And I have no disclosures or financial interest to any affiliated organization. So let's get right into it. First, the objectives for cardiac mass evaluation on echocardiography is to first confirm the presence of a mass. So we usually achieve this with an anatomical survey, which is basically, the short axis from the base to the apex, 4-3 and a 2-chamber imaging, potentially using a stack kind of imaging where we sweep across, and that'll also help us exclude artifacts. Then we identify the mass and put it in the box, okay? We fix the location of the mass so that we know exactly where it is, and this will be helpful for now and also for future surveillance imaging. We then decide to describe the mass. Where is the attachment? What is the extent of the mass, the size, the mobility, and the potential for hemodynamic consequence, such as involvement in a valve function, like stenosis or regurgitations, like a myxoma can do with mitral valve stenosis, and understanding the mechanism of it so that we can treat it. We also trying to find the etiology of the mass as well by identifying classic features that are unique to the particular mass. We then formulate a differential diagnosis and then decide, does it need to be ignored, such as an artifact, or a normal variant, and they have no clinical consequence? Does it need to be monitored if you're in any doubt, or if it's a benign condition with no particular clinical consequence, or does it have to be surgically removed as soon as possible? Remember, with echocardiography, you don't have a pathologic diagnosis. If you think about pathology, we are looking at gross pathology, and we are trying to find some features that could clue in on histopathology. So we are not perfect here, but this is a good start, okay? Now, let's say you have a consultation for something that was potentially found in X-ray imaging or in the ER with a portable ultrasound, or even in a CT scan, and you go ahead and do the echo, and we don't find the mass. Well, first, this is why we do the 4, 3, and 2 chamber and short axis stack imaging to see if we are missing it on the plane of imaging, okay? Second, we have to get full volume data sets, because remember, with 2D imaging, you're a singular plane, and the thickness of the plane is pretty small, okay? And we have to do this 3D volume in 2 different orthogonal planes so that our 90 degrees capture the entire volume of the heart so we can evaluate the mass within it. Then we must strongly consider the need for microvascular contrast agents, because all of a sudden, small little thrombi show up, okay? Case 1. So this is a subcausal image of a patient, and if you look at the initial picture, it looks like a singular circumscribed mass, but as we let it play, we can see that it's separated, and there's a thin fossa ovalis cluing us to the potential diagnosis, okay? All right, so diagnostic considerations. First, exclude artifacts. Second, look at the structure of interest and decide if it's a normal variant. Third, we have to think of it, we have to think if this mass could represent a thrombus and can be easily anticoagulated. For example, if it's a ventricular mass, we're looking for regional wall motion abnormalities associated with the mass. You know, if it's an atrial mass, we're looking to see, for example, the right atrium, we're looking to see if this is a catheter-associated thrombus. Sometimes these catheter-associated thrombus can develop not just from the catheter, but in the adjacent myocardium by causing friction irritation of the wall, and then eventually thrombi can form over there. Third is this patient presence with infective endocarditis and has blood cultures positive, and this is very likely just a vegetation. And when we have done all that, then we can, and excluded all of them, we have to still worry. We know that it's a neoplasm, and then we have to worry whether it's benign or malignant. Clinical features of cardiac neoplasms. The most common way that they present is patients are asymptomatic and they're found incidentally. You're not even thinking that it's going to be there. Second, they have specific systemic effects like a lymphoma with weight loss, fever, malaise, lethargy. Third, it could be because of an embolic phenomenon, a patient who are otherwise not suspected to have one. If it's a right-sided mass, you will end up with a pulmonary embolism. If it's a left-sided mass, you may end up with a coronary embolism causing myocardial infarction. cerebral embolism causing TIA or CVA, or if it gets through both and goes down the arch, a visceral ischemia, and without any particular reasons for it. If it causes myocardial infiltration, you're going to see it, of course, and it may cause pump dysfunction if it's present for a long period of time, causing CHF, or it could either obstruct the valve intermittently and cause stenosis, or interfere with valve function, causing regurgitation, or just by being present in the ventricle or the atrium, it can cause atrial arrhythmias or ventricular arrhythmias. Of course, the atrial masses will cause atrial arrhythmias, the ventricular masses will cause ventricular arrhythmias. The last part, and this is a little more difficult with echocardiography, is adjacent masses can cause direct cardiac invasion, which is going to be outside of our acoustic field, or may cause mass effects. For example, a hiatal hernia can cause mass effects on the heart as well. Okay. We'll start with metastatic cardiac neoplasms, as these are the most common masses that we are going to see within the heart. It is 40 times more common than primary cardiac neoplasms. Around 0.7 to 3.5% of the general population is going to have it. Okay, 9.1% in metastatic cancers, and 14.2% in those suffering from stage 4 disease. The spread can be of different types: hematogenous from a melanoma, that's most likely, most common, or other carcinomas or sarcomas; lymphatic, when the, for example, a leukemia or lymphoma, which is usually present within the lymphatic system, can do it. Direct intervention from a mediastinal tumor or mass, such as a lung cancer, breast cancer, or posteriorly from an esophageal cancer, and in the mediastinum, the center from a thymoma or a thymic carcinoma. And for the most part, for the boards, we have to be very careful about the venous extension. For example, lung cancers can come through the pulmonary veins into the left atrium and cause masses, or hepatic cellular cancer can come through the hepatic veins into the IVC and come into the right atrium, or renal cell cancer can come through the IVC to the right atrium, and so can the leiomyosarcoma do that. Disease location will determine the clinical presentation, and more than 60% of cases, especially which are just outside the heart, will cause some pericardial inflammation and then effusion, and many times will end up with a tamponade physiology. Okay. Very important clinical vignette: if you have a sarcoma and you have a pericardial effusion, if you tap it, you're not going to get cells. Whereas if it's a lymphoma and you have a pericardial effusion, you tap it, you're going to get cells. So this is one of the board review vignettes you have to be aware of. Myocardium, in more than 30% of cases with myocardial mets, you're going to have the classic chest pain from demand. ACS, if it involves, from demand as well. And arrhythmias, if you have ventricular arrhythmias, if you have ventricular masses. If it involves the endocardium, and this is very important, then you can have like thrombotic endocarditis, merantic endocarditis, where you get aortic valve masses which look like vegetations, and you can have, and you are at very high risk of systemic embolism, especially with mitral and aortic valves. Metastatic cardiac neoplasms, if found, indicates widespread disease and very poor prognosis. Our goal is to improve quality of life and delay any symptoms if possible. In a large study, it was found that melanomas, breast, lung, and lymphomas are the most common metastatic neoplasms to the heart. Sorry, case 2. A 59-year-old man presented with locally advanced oropharyngeal cancer with pulmonary emboli. And this is the 2D echo with 4-chamber on the left. We got color Doppler on it to check to see the flow of blood within the mass itself. On the right side, we've taken a full volume data set of the ventricle. And the beauty of this is, given that this is a right-sided mass, we are able to produce imaging planes in which the mass is well splayed out to identify, to understand the attachment, which is broad-based, the associated left ventricular dysfunction in the places where the mass is attached, and then the friability of the mass toward the endocardial surface. If you look closely on the still image, you will find that there is a lot of heterogeneity to the mass. And in the color Doppler, you'll see that within the mass, the color Doppler is entering it, showing that the shape of the mass is probably very lobulated. Once we find this, and we had sent this patient for a cardiac MRI, on the top screen is going to be a 4-chamber, kind of a 5-chamber image to splay the mass well. Right here is the mass in total, and we've just seen some of the contrast from the gadolinium contrast enter the heart. And as you see, the mass gets smaller and smaller and smaller. The reason it gets smaller is part of the mass is perfused and part of the mass is not perfused. This shows heterogeneity and vascularity. Similarly, you can see the bottom chamber in which you can see the short axis image slice through the maximum dimension, and you can see the mass gets smaller and smaller. The one outside is the one that receives the blood flow, and you can see the one toward the endocardial surface slowly loses it and may even be a thrombus. This is more MRI pictures showing the heterogeneity of the mass and the delayed enhancement pictures showing a thrombus within it. Now, in this, the MRI is a very good adjunct to echo to characterize tissue masses. And it can tell us, for example, over here, we have nulled the fat, but the mass does not have any fat, it doesn't get nulled. The delayed enhancement picture shows a thrombus right here within the mass. And these are the kind of things that we need to further characterize the mass. Okay. Case 3, a 64-year-old man with incidental mass on a transthoracic echo. This mass, you'll see a still image here with a parasternal short axis showing a mass in the right atrium. If you can't clearly see it over here. And then you can see the color Doppler showing blood flow around the mass over here and over here, suggesting that the mass has incompletely obstructed the vein. And over here, you can see an apical 4-chamber with a mass as well. So this is most likely a venous clot obstructing, getting into the right atrium. So the next step in the management of the patient, you just get a T-guided biopsy on it. Do we do an MR imaging? Do we need to get a cath-guided biopsy? Or do we need to do more pictures to delineate where the mass is coming from and understand this better? The answer is to do more imaging, especially. So this is the right atrial mass. So we need to look at the connections of the right atrium. And most of the tumors originate in the abdomen and come through the IVC into the right atrium. So we did subcostal IVC imaging. You can see a nice tumor coming in coming into the right atrium. Okay, so always the clinical vignette is always integrate the systemic venous connection with a suspected RA or RV mass. And similarly, if you're in a left atrial mass, you have always investigate the pulmonary veins on TE to see if it's coming from the pulmonary veins as well. Now, in this particular case, the patient had a right kidney tumor that came up through the IVC and into the heart. Key takeaways from the metastatic neoplasms is very common, 40 times more common than the primary cardiac neoplasms. The clue is that the mass does not respect tissue planes. 14% have high-grade disease. 60% will have pericardial involvement with that may progress to tamponade. And presence of a metastatic tumor in the heart usually is a very bad prognostic predictor. Primary cardiac neoplasms. First, we'll go through the malignant primary cardiac neoplasms. Most of them are going to be in the right-sided cardiac chambers. They are usually broad-based. For example, a myxoma is narrow base attachment. A thrombus attached to a catheter will also be narrow base and then slowly become larger. They always have ill-defined margins. They may infiltrate and affect wall motion. They do not respect tissue planes, and they may be associated with a pericardial effusion if they continue to go through the layers of the heart tissue. 25% of primary cardiac neoplasms are malignant. Most of them have poor prognosis. The most common one on the boards is going to be an angiosarcoma. The second most common is going to be a lymphoma. The others, which is of less consequence and probably not going to be tested, are liposarcoma, osteosarcoma, rhabdomyosarcoma, fibrous histiocytoma. Leiomyosarcoma is usually going to be a case with IVC mass that will be followed all the way to the uterine veins, and undifferentiated sarcoma. For leiomyosarcoma, the malignancy arises from the smooth muscle cells. Usually, it's a left atrial mass that is around the left intra-atrial septum and very close to the mitral valve. And it may involve the mitral valve if it goes towards the mitral valve, or it may back off and come into the pulmonary veins. The second one that we have to be worried about is lymphoma. These patients will always have B symptoms, which is fever, malaise, and weight loss. They're usually right atrial, and they may or may not have pericardial involvement. But if they do have a pericardial involvement, they may present with tamponade. And if they have a pericardiocentesis, you're going to have cytology that is positive. Okay. Then you have osteosarcoma, which usually has bone-producing cells. So this will be large masses that infiltrate into the wall of the heart. And within the mass, you can see calcifications. Okay. Rhabdomyosarcoma is a malignancy of the muscle cells. You know, they're pretty rare, so very unlikely to be tested on the boards. Angiosarcoma usually presents in a 40-something patient, young adults. Most common site is right atrium, but they may throw in an AV groove mass on you as well. They're usually very large, lobulated, very heterogeneous. They infiltrate and cause wall motion abnormalities in the area of the heart. Microvascular contrast agents may or may not cause enhancement depending on the histology of the tumor. If the vascular channels are fully open, then the microvascular contrast will get into it and they'll enhance the mass very well. If on the other hand, they become very high-grade tumors, then these vascular channels may get slit-like, and then the enhancement may not be as much. Now, these tumors are aggressive and they replace the atrial wall with tumor. For echocardiography, we see mostly the wall continuum and the inside of the cavity, but these masses may grow outside and be much larger than we actually see on echocardiography. They almost always never have a stalk, and that differentiates them from a benign myxoma or a papillary fibroblastoma. They have pericardial involvement, and the pericardial involvement is usually bloody, but when you tap them, there will be no cells for cytology. If it is in the AV groove, they may cause tricuspid valve dysfunction. Very frequently, they have lung mets as well. If this is a left-sided angiosarcoma and the mets are not yet present, that's the best case scenario for the patient. Many times, patients opt to undergo surgery just to surgically debulk the tumor so that they are symptomatically better. Overall prognosis is very poor. 90% die within 1 year of diagnosis. This is a picture of a large right atrial mass. It's pretty much replaced the whole right atrium. And within it, you will see heterogeneity, showing that this is an actively growing tumor with areas of necrosis. And they may almost always interfere with valve function and filling of the heart. This is to reiterate the fact that on echo, we're going to see this outline of the heart, and we may miss all of this tumor that's around the heart and is outside our acoustic window. So most of these patients will get a MRI scan to determine the extent of the tumor, and it'll pretty much surprise you when you see the tumor. So clinical PERS for angiosarcomas, right atrium or AV groove location, bloody pericardial effusion, which is cytology negative to differentiate it from lymphoma. You can get a surgical or a percutaneous biopsy, and the prognosis is pretty poor. The biopsy doesn't usually change a whole lot. Benign primary cardiac neoplasms. We'll start with the lipoma. 8.5% of all primary benign tumors, the heart and pericardium, are lipomas. Most common in adults, usually single. Clinically silent, it's something you pick up incidentally, and you may have an EKG change with a new EKG change that prompts you to do the study, and you may find it. Very, very rarely do they become symptomatic. And if it's symptomatic, then we may need to do further studies to either verify the diagnosis or to confirm that to exclude malignancy. It depends on the location. If it's epicardial, it can cause coronary flow obstruction. If it's myocardial, it can cause conduction disease or arrhythmias. If it's endocardial, it can cause intercavitary blood flow obstruction. Rarely, it can lead to an arrhythmia that can cause sudden cardiac death. This is a right atrial mass, and in the cavity causing flow limitation. This patient had a CT scan first, and you can see it's similar to the fat, and then had a MRI imaging. So you can see this is a adipose tissue here. It's similar intensity to that, and then we apply a fat suppression sequence, and the fat in the tissue is suppressed here, and the fat in the mass is also suppressed here. So that kind of verifies that this is a lipoma. Pathology, usually this is also broad-based. That is one of the reasons why people may get an MRI to see if it's a malignant tumor or not. Most of them are, asymptomatic, and if you follow up in a year and they don't grow, that should be enough. Surgical evaluation is very rare. And if you do it, um, it's for symptoms, and we must do an angiogram before that so that we can guide the surgical preparation. Lipomatous atrophy, we saw that. I just wanted to give you a MRI image with a stack imaging to show you that the epicardial fat is in continuation with the the fat in the septum itself. And from our standpoint, this is a very easy diagnosis to make. It's a dumbbell-shaped mass bearing the fossa ovalis, diameter less than 2, maybe sometimes large. It is in continuation with the epicardial and pericardial adipose tissue. Is non-encapsulated hyperplasia of normal fat cells. Echo imaging is enough, but sometimes these patients end up going directly to the cardiac surgeon, and they may get nervous and order a cardiac MRI, and then you can easily diagnose it. So this is the answer to the question that we had in the beginning. Now, if you did a cardiac MRI, what you will see is you'll see very bright dumbbell-shaped structure, and if you apply a fat suppression sequence, they become black, just like the surrounding fat in the adipose tissue. Now, from an imaging standpoint, if you find a tumor, if you find a mass, and they're intracardiac and and you verify that it's a thrombus and you anticoagulate it, you can just have to follow with serial imaging for it to be gone, and then you know the diagnosis and no further treatment is needed. If you have a lipoma, and lipoma is hypertrophy of the interatrial septum, you generally do not need surgery, and you may need some surveillance for it. And a TTE and a CMR approach provides specific diagnosis of these intracardiac masses, obviating the need for any surgery. Cardiac myxomas, most common primary cardiac tumor, 50%. Some physicians think that maybe papillary fibroblastoma is becoming more common. The location is usually 80% left-sided, 10 to 20% right-sided. Less than 5% are ventricular. The attachment is usually to the atrial septum. They are smooth, they are oval, they have to have a peduncle, and they should be attached to the interatrial septum and anchored to the fossa ovalis and nowhere else. When they get, that would be your exam presentation. When they get larger, the mass becomes more heterogeneous due to necrosis and calcification. And because they have necrosis and calcification, and because they sometimes can get lobulated, clots can get into it, and they can cause emboli. If it's left-sided, it's going to be, stroke or heart attack. If it's right-sided, it could be even PEs. They can cause obstruction if it goes into the mitral valve. They can cause arrhythmias, mostly atrial. Management is surgical excision. Now, with the myxomas, the recurrence risk, if the tumor is not completely surgically resected, is high. So most surgeons would want to resect the mass, make sure there is no pedicle, and inspect the interior septum on both sides to make sure there's no remaining myxomas. They arise from pluripotent mesenchymal cells, and that's why the mass is heterogeneous. And they are often interlaced with a thrombus, so that explains the embolic potential. This is a classic TE picture of a myxoma that is getting through the mitral valve and can cause some obstruction. So I wanted to show you some MRI images as well. So we see the myxoma attached to the fossa ovalis, large, lobulated, oval. This one's not really going through the mitral valve. We got another one here with a different imaging, to show MRI imaging, of course, that shows the mass very well. And this is basically to show the heterogeneity and delayed enhancement with a little bit of clot on the inside of the cavity. That pretty much looks like a malignant tumor, only this is This is slow-growing tumor, and the classic location is the reason why we believe it's a myxoma. Okay. Very rarely, it can happen in young males who have a family history of cardiac tumor, and they may be in atypical locations, such as a pulmonary valve, left atrial appendage. They may be multiple, just not one, and they may be extracardiac. Most frequently in women, breast, and men, and the testes. They may have blue nevi of the face, trunk, lips, and sclera, and they may have endocrine disorders as well. And the constellation of these is called Carney syndrome. In clinical pearls, high confidence of diagnosis is if the mass is the left atrium and attached the fossa alveolus in the atrial septum. Differential diagnosis is going to be a thrombus, a papillary fibrillostoma, lipoma, or metastasis. If you have endocrine symptoms, atypical location, or if they are multiple, we have to suspect that this may be inherited and part of a Carney syndrome. Masses on valves. There are several masses that can appear on valves. Papillary fibrillostoma is going to be top on the list for us. Lambl's excrescence. The valve itself may be fenestrated. There can be blood cysts or non-bacterial thrombotic endocarditis with cancers and just infective vegetation. So let's look into papillary fibrillostoma next. So this is a classic CNA1 kind of picture of a papillary fibrillostoma. You're going to, it has those linear strands over here, and clinical associations usually with endocardial injury, sometimes surgery, radiation, and classically you may get a question where patient underwent surgery for hypertrophic cardiomyopathy and has papillary fibrillostoma developed in the area. It is associated with embolization, mostly left-sided embolization. Histopathology is avascular lesion with a single layer of endothelial cells consisting of elastin, collagen, myxoid tissue, and smooth muscle cells. The origin seems to be hematomatous. Classic image on our TE, you can see right here the location of the valve on the edge of the valve, small, usually less than 1 centimeter globular pedunculated mass. It has this little shimmering edge to it. You can see that moving around. The movement of the mass, if you look at it very closely, is usually at right angles to the valve because it's moving with the valve but is moving away and has independent mobility. Valve dysfunction is usually not common, and is not the reason why we take it out. The reason we take it out is embolism. And if you have any valve regurgitation, it's usually regurgitation more than stenosis. It does not interfere with ventricular function at all. This is an MRI picture of the same. You can see the papillary filament attached to the very tip of the valve and showing that independent motion at right angles to the valve. So this is a perfusion image. We are giving gadolinium contrast, of course, and the mass appears black throughout the perfusion image, showing that it is avascular. In a 3D image, you can see it over here, and there's another papillary fibrillostoma image. This is in a surgery. They remove the entire papillary fibrillostoma out, and so that they can completely resect it. They'll usually look for other masses as well. Workup for a papillary fibrillostoma, blood cultures to make sure it's not just a vegetation, CBC and ESR for systemic inflammation, anticardiolipin antibody, and lupus anticoagulant, antiphospholipid antibodies for lipid sacs endocarditis. Clinical pearls for papillary fibrillostoma. They're usually small mobile tumors Aortic valve supposed is now looks like it's more common than even the mitral valve. The edge is shimmering. It's 90% of all masses are going to be pedunculated. They have to give you a question with a pedunculated mass. It is associated with embolism, 6% for 1 year and 13% at 5 years. If symptoms of left or if there's a left-sided papillary fibrillostoma and a patient is surgical candidate, we got to get it out of there. The surgery is usually a shave excision, very simple surgery. If symptoms of left-sided papillary fibrillostoma, not a surgical candidate, we can consider antiplatelets because a lot of these fronds have some platelet plugs in them, and antiplatelets may help, or choose anticoagulation. If it's right-sided and asymptomatic, we usually don't treat it because all they may result in is a very small PE. The tests to consider, of course, blood cultures and rule out for lymph sacs with ANA and dsDNA. Okay, the close counterpart of papillary fibrillostoma is going to be a Lambel's excrescence. These are, if you see it right here, you can see a little tiny fibrous strand. And they're usually very tiny. Many times we don't actually see it during echo. They are pathologically similar to the papillary fibrillostoma. However, they don't have the rounded mass at the end of it. It occurs in the lines of valve closure, and there may be multiple. They are always linear. As you get older, you'll start seeing more and more older patients with Lambel's excrescences. It's considered to be a degenerative process of valve closure over years. The likelihood of a systemic embolization happening from a Lambel's excrescence is very rare. However, very important point is, if you are undergoing surgery, and if you find Lambel's, you have to really make sure it's not a papillary fibrillostoma, especially if it's a valve replacement procedure where they're going to go in there and, for example, a mitral valve or a bypass is going to be a big decision because then they have to actually do extra surgery and more bypass time. So, and you don't want to miss the opportunity of not doing it. At the same time, you have to be absolutely sure it is a papillary fibrillostoma, not a Lambel's excrescence. Immune-mediated valvular disease, non-bacterial thrombotic endocarditis, underlying malignancy, SLE with Lymph-sac endocarditis, and antivascular antibody syndrome can cause these things as well. If you see with the non-bacterial thrombotic endocarditis, it looks like this, where the leaflet at the edge is thinner, and then towards the middle, it gets more rounded, and it may involve all three of them. Most of them are associated with malignancy. They have high embolic potential, and we don't actually suspect it, because we're not looking for endocarditis. This is an incidental finding when we're doing it for a stroke, So having a high index of suspicion is very important in diagnosing non-bacterial thrombotic endocarditis. Moving on to cardiac tumors in children. The most common is going to be a rhabdomyoma. The second most common is going to be a fibroma. The others are very infrequently tested. So this is a classic example of a rhabdomyoma. We were able to get a adult pass along access for this patient, just for our interest. It is most commonly it's going to involve the septum. It's most commonly multiple, like 1, 2, 3, 4, 5. This patient had like 15 of them. Very homogeneous, very well circumscribed. This is just a spot diagnosis on echocardiography in a kid. These tumors spontaneously regress, which is hard to imagine with a patient with so many masses, and no surgery is done for that. They may be associated with tuberous sclerosis, which is a trait of seizures, mental retardation, and facial angiofibromas, which look pretty much like a bunch of moles, you know. They're autosomally dominant, so they'll have family history of the same thing. Fibroma, second most common pediatric primary neoplasm. It has fibroblasts interspersed in the collagen. So this whole thing over here is a fibroma. It is pretty much along the ventricular wall. We have to look for like little specks of calcium within it. And that is a characteristic of fibroma. It is well demarcated. It grows into the cavity and may eventually interfere with the filling of the ventricle. They're often multiple. And because they're in the ventricle, they may cause heart failure and ventricular tachycardia. This is an MR image. When it becomes large, you get nervous and you try to get an MRI done. And you'll see that they're pretty much in homogeneous with the muscle of the heart. And all of a sudden, when you do delayed enhancement, there's so much fibrous tissue, and all the gadolinium gets into it and lights up. And this is a normal myocardium over here, which is black. Okay. So that is a pathognomic of fibroma. Final takeaways, clinical presentation can provide clues to the diagnosis. We need to always confirm the mass in multiple planes before we undergo a large diagnostic evaluation. We absolutely exclude artifacts, normal variants, and thrombus. Location is the most important thing in cardiac tumors. Echocardiography cannot give a pathologic diagnosis. We start the evaluation with echocardiography. We have excellent information from echocardiography, but it cannot give you the diagnosis. CT and MRI can be excellent adjuncts. For example, the tumors, renal cell carcinoma, leiomyosarcoma, and coming through the hepatocellular carcinoma, coming through the veins and into the IVC, and the pulmonary veins from the lung cancer coming through the pulmonary veins, left atrium. CMR, if you have a large mass, it's great. If you have very tiny masses, CMR is also hard because it is very motion dependent, and tissue characterization needs a static image. So thank you very much. Please let me know if you have any questions.
Thank you, Dr. Fernando. That was really an excellent talk. There are some questions about, if you can explain again how to differentiate Lambel from fibrillosarcoma.
Yes. So I think of Lambel's as the same continuation of a papillary fibrillostoma. If you, on echocardiography, most people will say in the aortic side is going to be the papillary fibrillostoma, and the ventricular side is going to be the Lambel's excrescence. In histology, if you say it, if you'll have a valve along the valve edge, you'll have linear tissue strands that come off from it, and that's usually Lambel's. Lambel's, because it's a fibrin stand, it doesn't collect any clots, and it really doesn't have to. We really don't have to do anything more than that. Whereas fibrillostoma, you'll have along the valve edge a thin strand, and on top of the thin strand we'll have a big oval mass, and it's like if you have a ball attached to a string and you keep flopping around, it's going to go in multiple directions independent of what you want to do. So same thing with the valve, it's going to go up and down, and then the papillary fibrillostoma is going to go this way, and that's how you know that it is there. Usually it is hard even for the surgeons to do procedure on them because it's so small, it's under 1 centimeters. They go there, they don't find it. It's a big surgery, you open up the patient for it, and they don't find it. It's a big problem for us. So that's why we, do an MRI or something else and confirm the presence and 100% sure that it is there before we get the patient in. Now, for papillary fibrillostoma, they have high embolic potential. So that may be the one that you find, but they may have other papillary fibrillostoma that have caused embolism. And you may almost always, if you look at the TE image, you'll see the papillary fibrillostoma, but you can sometimes also see fibrous stands on other valve closure sites. It's hard to tell whether they're already embolized or it's distal ambulance excrescence on the other side. Hope that answers your question.
Yeah, no, that answers perfectly. I don't see any more questions at this time, though.
Thank you very much, Rajiv. Thank you, Roy. That was an excellent review, Rajiv. Thank you very much. I saw quite a few MRI pictures too, so that's always fun to see them. Thank you again. I'm going to move on and introduce our next speaker, who is actually our last speaker for today. We are only doing 3 talks today, as I mentioned earlier, because the 4th speaker had a conflict. And instead, we'll be doing 5 talks on next Saturday. The next speaker is Dr. Rada Mahmood. Dr. Mahmood is a native of Michigan. After completing her medical training at Wayne State University School of Medicine, she did her internal medicine training at Oakwood Hospital and Medical Center. Before starting her cardiology fellowship at Beaumont Health, she completed an outcomes research fellowship at the University of Michigan and a vascular medicine fellowship at the Cleveland Clinic. As a vascular medicine fellow, her interest in ultrasound grew, and she greatly enjoyed her time in the cath lab as a general fellow, and as a result, went on to complete a structural echo fellowship at Washington Hospital Center and is now working in structural interventional echo at Wellstar Kenneth Stone Hospital in Marietta, Georgia, where she can combine both her interest in echo, ultrasound, and invasive procedures. In her free time, Dr. Mahmood enjoys to travel, hike, and spend time with her family post-pandemic. Her goals are to visit New Zealand and Australia, as well as get back to one of her favorite pastimes of trying new restaurants and cuisine with friends. We all hope that the pandemic will give us some relief soon and we can pursue our interests again. Over to Dr. Mahmood.
No, Rashid, I think she's trying to log in. We'll just have to give her a few minutes.
Sounds good. If people want to take like a 5-minute break, I think that should be fine. We are totally on time today, so if you want to just take a 5-minute coffee break and come back, I think that should be fine too. So, but we'll be live here, so you can just leave your computers on. We will start back at let's say 10:55 Central Time. Roy, I think that's good.
Yeah, that's good. Thank you.